Brilliant, great. Yeah, so I'm going to give you some perspectives from having a GP background with a lot of interest in how IT can help us to improve the sort of safety and effectiveness of our prescribing, basically sort of helping with decision making, which also is relevant to work that I've done as a researcher, where quite a bit of that has been around looking at the ways in which IT and computer systems can help us with our prescribing, but also in my role as National Clinical Director for Prescribing for NHS England, then there's also causing me to reflect upon this and to be thinking about, in particular, how AI might be able to help us with better prescribing and medicines optimization. So one thing I'd say from the start is that I wouldn't see myself as an expert at all in artificial intelligence. So in a way, I see myself as putting to you the sort of clinical and policy type issues that where I feel that artificial intelligence might have a role to play. And I think in, say, discussion afterwards, I think it's for you to be discussing and debating that. So I'm probably not going to be able to give you many sensible answers on exactly how one would use or employ artificial intelligence, but that some of the problems I've been presenting are ones that I think there may be an AI solution for. What I'd also say from the start is that it's important that anything that is developed is considered valid and reliable. At the end of the day, however much we may be supported as clinicians by computerized decision support, by AI, if a mistake is made and, for example, you end up in court, it's the prescriber who is almost certainly going to be in the court rather than the computer system developer. So it's just to be aware of that. It's that I just see this fantastic potential here, but I think a lot of work needs to be done to be ensuring that if AI does look like it's got an important role, and I think it potentially does, then those systems are made as reliable as possible, so they can be trusted by users. So just want to start off with some of the policy background where I'm coming from, and one of the key aspects of my role within NHS England is implementing something called the National Overprescribing Review, which I identified that while medicines do a lot of good, and we've got some examples on this slide, then actually there are limitations to that. So sometimes medicines cause more harm than good, and it's getting that balance right that's really important for us as clinicians, and of course is even more important for patients. So I sort of picked up on some things here which I think are relevant in terms of multiple long-term conditions. So first of all, just describing overprescribing. So this is used for a medicine where there's a better non-medicine alternative, or the use is not appropriate for that patient's wishes and circumstances. And then we have polypharmacy, which I'm sure you'll all be aware of, which just simply means taking of multiple medicines. And once again, that can do more harm than good, particularly in terms of what we might describe as problematic polypharmacy. It's not always bad being on lots of drugs, but sometimes it does cause problems. And that can include increased risks of medication errors and the associated harm with that. And one of the consequences of that could be increased risk of hospital admissions and in extreme circumstances, even death. And then if people are on lots of medicines, there's an increased risk that they're just not going to be able to take them all as prescribed, and therefore if they are working or potentially working, then there's likely to be reduced effectiveness. And then there's problems with waste, if people are simply not taking their medicines, particularly if they're just being stockpiled at home. Then there's economic consequences to that. The NHS is wasting money that could be used for something else, and of course there's environmental impact as well. So just think about particular concerns in relation to polypharmacy with multiple long-term conditions. So first of all, we have overtreatment. So that could be where we have people, and it may be that we've started people, say, on medicines for their blood pressure to try and get that really tightly controlled, or we might get their diabetes really tightly controlled, to try and use the best evidence to help people to live longer, to avoid strokes and heart attacks, etc. But you can get to a point where circumstances change, particularly as people get older, and you may actually be running into more problems than not. So it's not uncommon for me as a GP to see people in their mid-80s, they'll be on 3 or possibly 4 blood pressure tablets, and they're complaining of falls or dizziness. And doctors are trying to, in a sense, treat to targets, their blood pressure targets, which is why they're on so many medicines. But you're realizing that actually this could be causing more than harm than good. If someone blood pressure is dropping too much because of their tablets and they fall over and bang their head or break their neck or femur, it's almost certainly that's going to be doing them more harm than any good all those medicines were doing them. So actually identifying those situations where as people get older, we just need to be a little bit more judicious about the medicines that we use and recognizing risk of harm. There's then also something called the therapeutic cascade, which is where you end up using medicines to treat the side effects of other medicines. So, for example, this is in a book by someone called Lucy Pollock, who's a geriatrician. Someone has an injury, say, and they're put on a non-steroidal anti-inflammatory drug like naproxen or ibuprofen, and that may help a bit with the pain. But then they come in a couple of weeks later, have their blood pressure done, and find that their blood pressure's up. Well, it could be that the non-steroidal actually contributed to that. So then they're put on a tablet. So you might be put on say, a calcium channel blocker for the blood pressure, which probably didn't need to be treated in the first place. And then they might develop swollen ankles, and then they might be put on a diuretic for that. And then with the result of the diuretic, they might develop gout. Anyway, you get my point, that this is one of the things that can potentially happen, where people end up on lots and lots of medicines. There's then the treatment burden, which I've already alluded to, really, for patients and carers. And with that, there may be an issue to do with just the number of medicines they're taking, but sometimes it's the medicine regime. So sometimes you can make it a lot easier for patients if you can actually get their medicines down so they're only taking them once or twice a day, for example. And then a really important area is the use of medicines where the risk of harm is likely to outweigh any benefits that they're getting. So these are things where, already we have electronic tools, certainly in general practice, to help us with some of these, or we have easy access to guidance to help us with our prescribing. And what I'll be doing on the coming slides will be talk about some of the ways in which AI might be able to help. Just finally on this slide, it's just one just at the bottom left, just showing how prescribing in primary care has increased over time. So back in '94, on average, people were having about 10 prescriptions per head of population per year. And this is by 2017 has gone up to 20. So it's doubled over that time. That doesn't necessarily mean that prescribing is inappropriate over that time. We've had an aging population. But also there are far more indications for medicines. So if you went into a hospital with a heart attack in 1994, you might come out on 2 or 3 medicines. If you go into hospital with a heart attack now, you're probably coming out on 5 or 6 medicines, depending on the particular problem that was picked up. So it's not necessarily a bad thing, but it is pointing out that there is a lot of prescribing going on. So just want to also talk about medicines optimization. So you're aware of that, and I've got a slide showing that. But in context here, over a quarter of the population has a long-term condition. Over a quarter of people over 60 have 2 or more long-term conditions. As I've just said, with an aging population, use of multiple medicines is increasing. But also between 30 and 50% of medicines prescribed for a long-term condition are not taken as intended. So just in terms of the concept of medicines optimization, for any of you who are not aware of this, so this is really about just getting the medicines right and getting that balance between sort of benefits and potential harms. But it's also very much trying to encourage a patient-centered approach, so to understand where the patient's coming from, what's most important to them. So going back to my example of the older person who's got dizziness and risk of falls, it's probably more important to them for not to be falling over than to be hitting the target for their blood pressure, for example. So it's taking account of those views, those choices. It's taking account of evidence on the effectiveness of medicines, but also combining that with what we know about the safety of medicines. So you can have a very effective medicine, but it may not be as safe as another one. So you might actually opt for the one that may be just slightly less effective, but is safer, for example. And then just encouraging this to be part of routine practice. So some of the context, which I've always mentioned, is the National Overprescribing Review, which is the particular thing where my role was created in order to address the recommendations from that, where from addressing overprescribing, we want to improve outcomes, reduce harm, reduce waste, and we're also trying to promote better use of non-medicine alternatives. And I'll just quickly run through some of the things that we're doing in relation to that before getting on to the sort of key aspects I want to cover. So we're doing quite a lot of work. First item there with patients, carers, and people working in the health system to raise the issue of overprescribing and to be trying to change the culture a little around that and the expectation that there's a pill for everything and a cure for everything. We're looking at improving prescribing processes, reviews, guidance, and this is where clinical decision support and potentially AI could be coming in. We're also using digital technologies to address overprescribing, either through the fantastic information we could gather in primary care, in particular in the health service, to be identifying, for example, groups of patients who may benefit most from a medication review. We're working on improving the communications between primary and secondary care so that we've got better understanding of prescribing, a better flow of information around prescriptions. We're working to improve feedback to clinicians to guide prioritization and monitoring of successive interventions. Lots of work going on in training and development, particularly with pharmacy profession, and newly qualified pharmacists will soon be independent prescribers. There's also an important aspect I mentioned waste before, but looking at the carbon impact of unnecessary prescribing. And then also work has been commissioned to strengthen the evidence base around overprescribing and getting some of that evidence into practice. So just thinking about how AI might help to improve. So I've got 4 things down here, and I'm going to have a slide for each of those, and I'll then give some of my thoughts on these. So first of all, reducing medication error, where decision support when considering whether to prescribe a medication. Medication review is an important thing, particularly in primary care, and so I'll be talking about collation of information when undertaking a review. Decision support when you're then reviewing a patient's medicines, including identifying potential overprescribing, and then identify patients who may need additional support with their medicines. So there was a very useful review in the Lancet recently looking at use cases for artificial intelligence to reduce frequency of adverse drug events. So it's worth having a look at that if any of you have not seen it already. So they found, it's recent, so they found 78 articles, quite a variety of different articles using a range of AI techniques and a wide range of medications and adverse drug events. And several key case studies suggest that AI could contribute to reduction in frequency and consequences of adverse drug events. It's worth noting that most, 94%, were assessing technical algorithm performance and relatively few actually testing AI in clinical settings. So there's been an expansion. As you see, 74% of those articles published in the last 5 years. So there's been an expansion in interest in this, but I think it's yet to get to the point where we're getting some really very good quality work testing these things out in practice. But you know, that's where a number of you may be working on this already or wishing to work on it in the future. So then collation of information when undertaking a medication review. So when we're doing we have patients on medicines, then it's important that those medicines are reviewed from time to time. For example, for the reason I said earlier, that it may be that the condition has changed and you don't need to. You may be on more medicines, you may be on fewer medicines. But one of the things with doing that is often quite complex when you have people with multiple long-term conditions, because of the whole range of information that you need to pull together in order to do that. So, you know, if someone's got diabetes, you want to know all about their diabetic control. You ideally want to know that they've had an assessment of any complications from their diabetes. Similarly, if they've got high blood pressure, you want to know what their blood pressure is. But they may have asthma or chronic obstructive airways disease, in which case you want to have updated information about that. They may have mental health problems. So I think people have got a range of things, and what you're having to do as a clinician is to mentally collate all of that to work out all the various different bits of information you need in order to be able to assess whether patient is on the right medicines and whether it's reasonable for you to extend their review dates so they can carry on getting more and more prescriptions. So I'm going to give you just some examples of non-AI approaches, and then perhaps think about how AI could do better. So this is something from our practice. You don't need to look at the detail of this slide because I'll talk through it. But what we have in our practice, we can create templates using GP computer system to try and pull together all the information that you might need for a particular purpose, or for undertaking a particular clinical assessment. So what we do here is sort of pull together the information that might be useful for doing a medication review. So it will tell us their last blood pressure, pulse, their body mass index, their weight, when these things were done, their smoking status, alcohol. It will give us blood test results. This is really important for a lot of medicines. Then it's important to check that they are suiting the person, or it may be that below a certain level of renal function, you might have to adjust the dose of medication, for example. So this is just a sort of simple example of something that say in my practice just saves me a few minutes of time, because it just pulls it all together in one place. Something also available, it's a bit clunky, these things, but or look a bit clunky, but available in Nottingham is some guidance around structured medication review. So if you can see it, you'll see there's sort of 7 different steps to this, and there's a different screen for each of those, where you'd be doing that first thing, looking at the patient's history, their reviews, the bloods, and then going through a whole range of things that can maybe able to help you identify problems. For example, the stop guidance is picking up medicines that may be hazardous. The anticholinergic burden, I think we've probably heard of the anticholinergic burden. There's a lot of drugs that have cholinergic effects, and that could cause problems for patients. And if they've got a high anticholinergic burden, you generally want to try and reduce that and identify the medicines that are doing that. You could look at other high-risk medicines, so STOP will be doing some of that, but there are other examples. Then there may be in the quality and outcomes framework review, and then we get to reauthorizing medicines. So I'm just saying here, we've already got some mechanisms. There's a company called Ardens who also do things like this, and there are other companies that also produce information to help with this. So the question is whether AI could do better than this. I think in relation to this one, it's probably quite a big ask, but it'll be helpful to know your reflections on that. If, you know, what's required is recognizing the conditions that the patient has and the medicines they're taking, and then to be pulling together all the information that might help with a medication review, including identifying any potentially missing information. So in a sense, it's a bit like, could AI do even better than what we've sort of already got set up, and can it do in a reliable way and provide us with information about, for example, the source of any guidance. For example, if NICE is recommending that people's kidney functions checked every 6 months, for example. So then decision support when reviewing a patient's medicines, and then including identifying potential overprescribing. So when it comes to either prescribing in the first place or reviewing a patient's medicines, then, as I said earlier, we do have computerized clinical support, and I'd say it varies in terms of its quality and usefulness. So at the most simple level, then when we try and prescribe a medicine, you will always have a sort of screen coming up showing the potential issues with that medicine. So it would list if there are any contraindications, you know, reasons why you really should not be taking that medicine. It will list cautions. It will list the potential side effects. It will highlight if there are particular risks with interaction between other drugs that the person's taking. It will highlight if there are any allergies. But that's fairly, generally speaking, sort of fairly passive, and I think studies would suggest that most clinicians skip through that fairly quickly. But it can be useful. But it's not necessarily. It's only partially patient specific. So what you really want are things that jump out and tell you that in this particular patient, there is this contraindication, rather than all the contraindications there might be, or all the cautions there might be. And that's where some more sophisticated decision support will provide what are often more interruptive alerts, ones that sort of jump out at you to highlight a particular problem, and ideally to be pointing out what is the best solution. But it's always a really important balance for this, just in terms of just getting the setting right in terms of how much you alert clinicians, because I mean you literally could spend all your time reading these lists of cautions and contraindications and potential interactions. So we have got I'd say we have got a problem here, and it's one where there's potential, I think, for AI to help us with this. But once again, I think it's a big ask. But I do have this sort of idea that that in time, AI might be able to really help us here. That actually, in a sense, you would be looking at that particular patient. You know, say a 85-year-old patient with a whole range of different conditions, a whole range of medicines, and trying to see using AI, whether you can get some helpful feedback in terms of which are the medicines that are likely to still be helping them, which ones may be neutral, or which ones may be harmful to them, in a way that's much more tailored and much more sophisticated than we have at the moment. So that's something that, again, I'd be interested to talk with you about afterwards, if anyone's got any particular thoughts on this. I think we are a long way off that, because that literature review I mentioned, understandably, the early stages are just looking at individual test cases, individual conditions and medicines. When you're going up to this massive increase in complexity, when you're talking about different patients with multiple long-term conditions and polypharmacy, but I do see it as somewhere where, given the a tremendous amount of work that need to be done in terms of checking that this was as valid and reliable as possible, could actually be helpful to us in the future, and indeed could even be helpful in terms of discussions between clinicians and patients around their medicines. So then another one is identifying patients who may need additional support with their medicines. So, as I've said before, adherence problems, difficulty with managing medicines, and potential waste are important problems for the health service. And so could AI help identifying patterns to pick up patients who may need additional support? So I've just got a few ideas here. I mean, this is not one where I immediately springs out that AI is going to be the solution, but again, it would be useful to have your thoughts on this. We can do simple things like consider what's called the medication possession ratio, just looking at how frequently patients are requesting their medicines and whether they are under or over ordering their medicines. There could be poor apparent response to treatment. So if you're treating someone's blood pressure and you're onto a third blood pressure tablet and it just doesn't seem to be making any difference, it's pretty important to actually try tactfully to find out whether the patient is taking those medicines or how they're taking them. Certainly with polypharmacy, that's going to be a factor, but it's one that we could easily identify using our other systems. And then there's demographic factors, which we know something about already, but potentially AI could be helping. But it may be at the end of the day that's actually talking to patients, observing them, i.e. seeing what they've got in their homes and how they're managing their medicine, may be the most effective. But it's just another area where it might be that AI could help. So just to summarize before we get on to our discussions, while medicines can do a lot of good, they can also be harmful, and particularly when overprescribed. And I think AI has potential to help with better prescribing and medicines optimization. But as I've said, I think a lot of work needs doing to get us to the point where it is going to be well, we've got that assurance that it's a reliable way of and dependable way of helping us. So first of all is work on reducing medication errors through decision support. So whether the existing systems that we've got could be made even better when it comes to deciding whether to prescribe a medicine. The collation of information when undertaking medication reviews, the decision support on reviewing a patient's medicines, and then, as I just said, identifying patients who may need additional support for their medicines. So I'm going to stop sharing now, and then that'll give us an opportunity to have a discussion.